42-year-old woman presents to the clinic for a recurrent rash that has remitted and relapsed over the last 2 years. The patient states that she has tried multiple home remedies when she has flare-ups, but to no avail. The patient is wary of medical care and has not seen a doctor in at least 15 years. On exam, she has multiple disc-shaped erythematous lesions on her neck, progressing into her hairline. The patient notes no other symptoms. Lab work is performed as positive for anti-nuclear antibodies. What is the most likely diagnosis? Drug-induced lupus, systemic lupus erythematosus, cutaneous lupus erythematosus, dermatomyositis, or tinea facitis. I think I forgot to mark this one, but the correct answer here is cutaneous lupus erythematosus. And what in the stem will point to this? This thing, the disc-shaped erythematous rash. Okay, the discoid lupus. This is the classic description, and which should point you towards this. Another thing is systemic lupus erythematosus, as the name suggests, will have some systemic findings, classically like fatigue, joint pain, right, weakness or tiredness due to anemia. All of these classic SLE findings you usually see in case of systemic lupus erythematosus, whereas cutaneous lupus erythematosus mainly has, as the name suggests, skin findings. Drug-induced lupus will have a history in the question stem. They'll give a history of drug use, and they'll give a history of joint pain along with some rash. Right, so joint pain and rash and fatigue, malaise, all of that is classic for drug-induced lupus. And do you know what is the classic antibody seen in drug-induced lupus? It is the antihistone antibody. So they'll usually give that, or they'll ask about antihistone antibodies. But here it is the anti-nuclear antibody. ANI can also be positive in case of drug-induced lupus, but there is no history of drug, there is no joint pain or any other manifestation. SLE, they will be given classic rash as malar rash. It is not this discoid rash. You'll see the pictures in a bit, and there will be other systemic findings. Dermatomyositis, again, is seen in older patients, and there will be muscle weakness, specifically proximal muscle weakness, which is classic for dermatomyositis. And the rash in dermatomyositis is a heliotrope rash, which is seen around the eyes, and a shawl rash around the neck and the upper chest, which is a classic description of dermatomyositis rash. Tinea facitis. This is a fungal infection, and it's very important to know that the description of rash, they'll give you prescribed it as this ring-shaped rash with edematous border and central clearing. This is the description they'll ask. They'll put this in the question or give this in an option or give you a picture. Whenever you see this, you go to tinea facitis. It is a dermatophyte fungus. This is the discoid lupus, seen discoid lupus. Cutaneous lupus erythematosus. You see this disc-shaped rash. Whereas in case of systemic lupus, you'll see this classic malar rash. Right? You can differentiate it. This is a heliotrope rash of dermatomyositis. It covers the eyelids classically. There will be proximal muscle weakness. And this is the rash of the fungus, tinea facitis. You see this? There will be erythematous border. This is very important and classic. And there is central clearing here, you see. And this is going to be itchy. This is one of the main points of differentiating a fungal rash is that it will be very itchy and erratic. What are some of the drugs that cause SLE? Phenytoin. Classically, it is seen in hydralazine, isoniazid. These are the drugs causing lupus, right?
Thanks for watching. Please give a thumbs up and subscribe for more.